Well, in advanced non-driver non-small cell lung cancer, the first thing I would do would be to test for PD-L1. If that's high, 50% or more positivity for PD-L1, 20% maybe, 25%, I would give those patients pembrolizumab. For the other 75%, outside of a clinical trial, and certainly at Yale Cancer Center, we're looking for clinical trials, but if we, for the more general audience and in the absence of a clinical trial, we do a platinum-based chemotherapy. Which one to use? Certainly if the patient has non-squamous disease, these days we're pretty much using carboplatin pemetrexed. If someone has squamous disease, of course, pemetrexed is not approved in that setting, then you would probably use carboplatin paclitaxel or maybe carboplatin gemcitabine. In some cases with carboplatin paclitaxel, one might want to add bevacizumab, the angiogenesis inhibitor. I probably would do that if I was using that doublet. In the frontline setting, PD-L1 expression would be the sole determinant for who would get immunotherapy alone. As far as chemotherapy goes, performance status is critical. If someone had performance status 0 to 1, give them a platinum-based therapy. If they had performance status 2, I might move away from platinum and just give a single agent. That would be pemetrexed if they're non-squamous, and if they're squamous, maybe docetaxel, maybe even not treat if they're really in a poor performance status state. But most of those patients would get chemotherapy. For patients with non-squamous non-small cell lung cancer, which are the majority of patients who are getting chemotherapy alone, that would be carboplatin pemetrexed. I will offer maintenance to patients who have stable disease or response. And I usually start to discuss that after 2 cycles, if they have stable disease or response. And at 4 cycles, I will offer maintenance because maintenance has been shown to improve survival. If someone has squamous lung cancer, usually I don't do maintenance in that setting. I don't think the drug docetaxel is as attractive a drug to use. Pemetrexed is so much better tolerated, so I usually wouldn't do maintenance in the squamous cell setting. Someday maybe we'll be doing maintenance with immunotherapies or other agents like that. The key to maintenance is added value, added outcome with not a lot of added toxicity. But usually I do offer maintenance to the patients with non-squamous lung cancer. The options for maintenance in stage 4 disease are pemetrexed. I guess there are some data for EGFR erlotinib maintenance, but I think outside of patients having an EGFR mutation, I wouldn't use erlotinib in that setting. I think really the only maintenance drug is pemetrexed for the non-squamous patients. We need better maintenance options. We know that no one's cured with stage 4 metastatic lung cancer, as I'm sure you know. So then the question would be, maybe we want to use an immunotherapy or use something like that. And I think we're going to start seeing some trials like that in the future.